So, we studied yesterday earlier class various agents in anticoagulation class. I think we studied up to this ergotroban, I suppose. So, these are the agents, anticoagulants. We have seen the mechanism of coagulation, and we have seen that when it goes beyond physiological levels, it causes problem, and that leads to problems of obstructions in blood flow and consequent ischemias and organ problems. So, the next agent in this class or in anticoagulant class is ergotroban. It is an L-arginine analog. It is approved for use in patients with heparin-induced thrombocytopenia. The mode of action is binds to and it inhibits the thrombin, just like heparin-like action. Administration, it is intravenously administered according to this activated prothrombin time. The hepatic metabolism and bile, it is metabolized through hepatic metabolism and it is excreted in bile. Side effects, in earlier class I already told you, all of the drug will have very common adverse effect is hemorrhage when it is not controlled. If you remember that either APTT or INR shall be very important and has to be measured continuously or very frequently to avoid these problems. So, these agents are having adverse effect of hemorrhage. Then contraindication in existing bleeding condition or bleeding tendencies, and caution with the patient where there is hepatic dysfunction. If we compare these two agents, ergotroban and lepiridine, then in case of renal efficiency, whenever there is renal efficiency, ergotroban can be chosen, and when there is a hepatic insufficiency, the lepiridine can be chosen because of their elimination considerations. Then next in that class is drotrigogin ALF. It is a recombinant activated protein C. It causes reduction in the mortality in the adult patient with the severe sepsis. The mode of action is proteolytic inactivation of factor 5A and factor 8A. This is also administered intravenously. Side effect, as I told you earlier, side effects, very common side effect is hemorrhage. Just like in pharmacology, people tends to write adverse effect of each and every drug, nausea, vomiting, and they do even have tendency to write the antiemetic drug side effect as a nausea and vomiting. So, like this, if those who are studying over here or those who have common sense, they can understand all of these drug. They can have a side effect of hemorrhage. If you remember, similarly, those which are antihypertensive, in most of the cases we have seen the major adverse effects should be hypotension or postural hypotension. So, these are the matters of common sense which has to be remembered, which has to be kept in mind. So, this is the situation. The side effect is hemorrhage. Contraindication is again existing bleeding condition or bleeding tendency, and there is no antidote in case of overdose. Then next in this case is, so how these oral anticoagulants act. So far whatsoever we have seen from heparin and all its analog to the last one, all these are given by intravenous route because of their structural situations, and they cannot be given by oral route. So whenever any drug is intravenous, then definitely it is a problem. There was an exception we have seen, heparin or some of the heparin analogs, we have seen that can be given by subcutaneous route also. The problem with the intravenous route is major problem. If you compare or you can go through, you can remember the problem are intravenous. That means some expert has to administer, means the patient has to go to doctor, has to wait till doctor or the nurse or the concerned person, skilled person is there. When it is subcutaneous, then in that case it is not a problem, but still the problem of injection is there. Everyday injection or every time injection, that is definitely a problematic situation. So the problem, how to overcome, oral anticoagulants were thought about, they were preferred, and accordingly the most common and most widely used and one of the oldest anticoagulant in that category that are called as coumarins. There are two major in this are dicumarol and warfarin. Warfarin is structurally related to vitamin K. So it is used in case of treatment of embolism, may it be deep venous thrombosis or atrial fibrillation. Let me tell you that this question came into my mind. Why atrial fibrillation? What is the problem with atrial fibrillation? I'll just like to check. Actually, since last year I was not much aware about it. Let me tell you very frankly. So, anybody knows why in case of atrial fibrillation we need anticoagulant? I am asking, I am not expecting answer actually, but since I know that some of your students are reading continuously, they are trying to get good knowledge and try to answer the questions. So I just wanted to ask, can anybody? If you don't know, then just let me know or just write in chat box that you don't know. No, definitely the drugs are there to avoid clots, but how you relate with atrial fibrillation, that's why. Fine. Okay, no problem, Deepak. Yes. So last year or last to last year rather, I came across one discussion. I attended one seminar where all the discussion on this particularly anticoagulants actually. At Belgaum there was a big seminar, 8 days only on anticoagulant, and they were expected to make a anticoagulant pharmacist, the pharmacists which are expert in the anticoagulant treatment and anticoagulant management, because it needs, we'll see about this in next few slides. So for that it was actually there, and there it was there. We discussed with one of the physician over there, doctor over there. So during atrial fibrillation, what happens is the atrial rate of this atrial rate increases too much, and because of that the blood it is so fast that blood cannot move, and if blood do not move, then it stays at one place, and whenever the blood gets stagnant at one or other place, there are it increases chances of clotting. Then the problem is it is not in atria. From atria this clot can come into circulation and they can go anywhere, and it can cause obstruction or blockade to any other organ. The person may become prone to stroke or cardiac ischemia, or that is myocardial infarction. So in that cases, when it is diagnosed, even though there is no other sign of this atherosclerosis or stroke or anything, so in that condition, in atrial fibrillation, these drugs are given, and it has to be given lifelong, because still atrial fibrillation is there. There is a chances of still there are chances of the blood coagulation in the arteries, which can spread further and can cause obstruction. So it is most of these agents you will find in the treatment of atrial fibrillation also. So it is not any direct role in atrial fibrillation. They don't have any impact on atrial fibrillation, or they do not reduce any atrial fibrillation. But the complication which are subsequent to atrial fibrillation, for this these drugs are important. I hope it's clear now. And in patients with prosthetic wall, okay, prosthetic walls, prosthetic word anybody knows? Tell me, don't say yes now only. Tell what do you mean by prosthetic? Anybody? Yes, artificial organ, artificial tissues, tissues also. Okay, these are called as the prosthetics. So when walls are artificially made, in many people there are valvular problem, and because of that they can develop CCF. To avoid or to treat CCF, they need to get operated, and for them, since natural wall cannot be replaced as such, there are many artificial walls are nowadays made. And these walls, since they are external objects, they can cause, when blood come into contact with them, they can cause, or they can initiate the coagulation mechanism, and in that condition it has to be used, because the person who are having this prosthetic wall, they can be at the risk of thrombosis. The mechanism is its synthesis, it inhibits the synthesis of factor 2, and you can see the mechanism, that what happens into that, how this prothrombin is activated, and how the vitamin K plays important role into it, and the warfarin blocks this vitamin K activation, which is important for transfer of the ions, that is carboxylation. And once this is there, that will affect the factors, particularly you can see the squares over here, factor 10, factor 9, factor 10, factor 9, factor 7, and prothrombin. These all factors will be inhibited because of synthesis of warfarin, because warfarin will inhibit the synthesis of vitamin K, and this will cause the anticoagulation action. Now thing is, the warfarin is the most tricky drug, and therefore people feel that there should be specific training should be given to pharmacists or the people. We shall discuss why. First one is this agent, already I told you that it acts on the mechanism of action is vitamin K. So when it causes the problem, vitamin K activation or vitamin K synthesis or final steps, this step is very important. Now till the vitamin K is available in the body, till that period the coagulation will continue. That means the onset will not be immediate. Till there is availability of vitamin K, which was already synthesized, till that period the this oral anticoagulant or this derivatives coumarins will not able to act, is one thing. Second thing, we have already seen its structure related to vitamin K. The important thing about it is 100% absorbed, so that way is very good. So therefore we do not need any parenteral administration of it. But the biggest problem it has got is it is 99% bound to plasma protein. Now if you understand that 100 milligram of dose drug suppose given, it is not 100 milligram actually, the doses are from 1 milligram to 10 milligram. So suppose we have given 1 milligram dose, that is 1000 microgram. Out of that, how much? 99% is bound. That is 990 microgram is bound to protein. We know that if it is bound to plasma protein, it cannot show action, it will not be metabolized. Okay, that means only 10 microgram is free for action, and that 10 microgram is causing action. Okay, if any drug is displacing it, okay, Okay, then what will happen if any drug is displacing it by just even 10%, okay, from 90 to 80%. Till now, in that circumstances, the 20 microgram of the drug, that means double of the drug is available in the systemic circulation. Double of the free drug is available in systemic circulation. And you know very important thing about that, plasma concentration and the effect. The plasma concentration is a very very important factor. As the plasma concentration increases beyond certain level, that can cause toxic concentration, or that can cause the adverse effects. So as soon as it causes the release of the drug from protein binding, that is a big problem. The onset is 8 to 12 hour delay of onset of action. Why there is a delay in onset of action? I told you just now. The onset of action will be delayed because already vitamin K whatsoever is present in the body is one thing, and it is taking time for distribution. So because of these two things, it is taking time in the onset. So it will not able to act before 8 hours in any condition. So that is very important thing one has to keep in mind. Till that 8 hour, if you have emergency, then you have to use any intravenous anticoagulant agent. Okay. You will study this in more detail when you study it in therapeutics, because it is very important aspect of therapeutics, how to make the treatment with anticoagulants. So initially what has to be used, and then what next has to be done, and what are the care which has to be taken. But this is the basis which supports or which is helpful in the decision making when you study it in therapeutics. Okay. Hepatic elimination and excreted, it is eliminated by liver and it is excreted in the urine. It is only dicumarol is incompletely absorbed, while warfarin is 100% absorbed, we have seen. Side effect as others, it is also having hemorrhage. Contraindication in the patient with hemophilia or pregnancy, it should not be given in these patients. Then drug interaction, this is very very gray issue, what we can say, or very typical issue. Typical issue is that means it has got so many drug interactions. There are many drugs which will inhibit cytochrome 450 and they will cause increase in the elimination. Example, cimetidine like drugs, macro like antibiotic drugs, antifungal drugs. This will cause inhibition. Because of that, the metabolism will be slower one, lesser metabolism, that will cause drug accumulation. If it is accumulated, then the concentration will increase or it will remain in the body for longer time. Because of that, it may cause the more action or bleeding tendencies. The second one is there are drugs like which are causing cytochrome P450 and that will cause induction of this. Because of that, there will be decrease in the levels. Example, rifampin and barbiturates. Because of the decrease in the level, you need to have frequent doses, otherwise the coagulation problem will not be attained properly, or there can be still some coagulation and can affect. So treatment will not be successful. Then apart from that, it has got many food interaction also. There are many food items, example cabbage, etc. If you will search or when you will go for making your final notes, you will find that there are many fruits or many vegetables which are highly rich in vitamin K. So if they are rich in vitamin K, then your inhibition of vitamin A K synthesis through warfarin does not make much sense, and because of that food, the vitamin K is still available and the impact is not observed. Okay, so it has got drug interaction, it has got food interactions, and therefore, and it is the drug which has got 99% protein binding. So there are so many interactions this drug is having, and therefore it has to be monitored very very strictly. Okay, whenever we feel that there is a overdose of these agents, oral anticoagulants or coumarins, then we can give or we can administer vitamin K, or it is also known as a phytonadione. This can be administered, which will cause or which will take care of inhibition of vitamin K. Okay. So the next class of this is fibrinolytic. The most important thing before this warfarin is the warfarin has to be, again the INR has to be maintained below 2 or 1 to 2. So if this, already we have seen in earlier slides, if you remember, if the INR is not maintained, then there are extreme chances can be there. What can be the extreme chances? Either there are chances or tendency of bleeding, or there can be tendencies of clotting. Okay. So in any case, the person will not get benefit from the treatment, or rather the person will be in false security that the person is taking drug. Okay. And in such condition, the monitoring is very important. So INR has to be monitored, and if the INR is correct one, the patient is well guided about all the interaction, that whatsoever other drug is there, it has not to be taken without showing it to the expert. If any case is there, in that case, or if the person needs to take any drug, then immediately inform the expert and get the INR checked. If there are changes in the INR, accordingly dose has to be there. Interestingly, again, while you will make note, you will find that this is the only drug which has got tablets from 1 milligram to 10 milligram. So accordingly, the dose has to be adjusted. Accordingly, the tablet has to be prescribed. Okay, because it totally depends on INR. It depends on the food habits. It depends on the other drugs which are prescribed, and because of all situation, it has to be taken care of. Adverse effects therefore will depend, apart from hemorrhage. And there, when we attended that seminar, the doctor said that when the person is on warfarin, and if the person does not take or does not pay attention, the person get admitted with any of the consequence, and usually we have to see him in the emergency wards. Either the patient gets admitted in the emergency because of the severe bleeding, sometime it can be fatal, or the patient is admitted with the clot again because the dose was not sufficient. So that has to be there. But the biggest benefit of this is it is very easy to administer and very economical. The cost is very less. So most of the doctors still they have their own discussions whether they should go for coumarin or warfarin, or they should not go. Many feel that it is so economical that it can affordable to all the even poor people and all. Many feel that whatsoever cost it is saving as a drug cost, it is added up in the repeated INR measurements, because time is taken. Actually INR is not that costly, but it takes time in going to hospital, get it measured, take the report, so it takes time. So that is there is a dilemma in physicians. But those who says that if they find that in next 4 to 5 months, if the patient is nicely guided, the patient is adhering into the schedule, then it is one of the best drug. And still in India, it is most widely used agent is warfarin. So this is what important in if we consider as a therapeutic aspect. The next class of the drug, they are not actually anticoagulants. We call them as a thrombolytics. Thrombo, we know, thrombus. Lytics means breakdown. These are the agents which break down the thrombus. So what are these drugs? This is important in that is tissue plasminogen activators. We know plasminogen activation, that plasminogen is activated, and because of that plasmin is formed. Plasmin is the agent which causes the breakdown of fibrin threads. When we were seeing the physiology, or here also you can see. So this plasmin is there, and this plasmin causes the act on the fibrin threads, and these are the split products. So something, if we have got a tight rope or various thing, and you cut the rope at various places, then that strength has lost, and because of that the clot is dissolved, or clot is broken down. So we can see this is the physiological mechanism, that there is various mechanisms are there. There are proactivated of blood there, because of stimuli it is there, okay, and it is activated. There are some anti-activators are also present. So this is, we call it as a tissue plasminogen activated, or we know that urokinase, which is from kidney. Then and the drug wise also we know, example is a streptokinase, it is an activator. So it will activate the plasmin, and this plasmin is acting on fibrinogen and degrades it. So there are other agents like anastrapase, etc. They are acting on this one. So there are many such agents in that. This Alteplus, if somebody wants, they can just check the prices of that. Still nowadays, because of the recombinant technology, and they have reduced. But once upon a time, Alteplase was costing around 37,000 per vial. That much is the cost. It is very, very costly. Streptokinase rate somehow decreased in last few years, but still it was around 10,000, I remember. So these are the very, very important agents. This is the only drug or as a medication, if if the person is not going for other treatment, if you remember. Okay, very good, Sanika. So if the person is not going for angioplasty or such thing, these are the most important drug for myocardial infarction. Alteplase is the most important in the stroke as an immediate treatment. So these are the important one. This is mode of action are they are serine protease. Serine is amino acid which is important, or which is an active moiety of protease, that is the enzyme which causes breakdown of protein. So it is a serine protease which causes activation of plasminogen, means when plasminogen is a big molecule, so when it is cutting, then its active sites are opening. So like that it is there. Then this, it causes increase in the plasmin levels, and the clot specific, and it will cause binding to fibrin, breakdown of fibrin. So the drug retiplase is less fibrin specific. The tenecteplase is having longer half life, and it is more fibrin specific. Then next in this class are urokinase. I told you urokinase is from enzyme obtained from urine. It directly activates plasminogen. It is isolated from human kidney, and there are less chances of having an allergic reaction, because these are the enzyme substances. All enzymes are protein, you know. These are the proteases, these are the enzymes. These enzymes are causing breakdown. This breakdown of protein, they are also causing protein breakdown, and this being a protein molecule, enzymes are a protein molecule, they themselves can have hypersensitivity reactions. So these are the major adverse effects they can have, but urokinase will not have, because it is obtained from human urine only, because it is known, or human body recognizes it as a substance present in the body, or ubiquitous substance, and therefore it will not show any kind of hypersensitivity reaction. Then next is streptokinase. It is from streptococci. Anastrapase is streptokinase and plasminogen, and they are combined with plasminogen to form an active complex that convert plasminogen into plasmin to dissolve a fibrin. This is what the mechanism of action which we have earlier also seen. These are the agents they are acting. So we know where they are used. They are used in a pulmonary embolism with hemodynamic instability, severe deep venous thrombosis, where the thrombosis it has causes a very big occlusion, and acute in myocardial infarction, if a person is not going for, as I told you, angioplasty or immediate CABG, then the immediate injection of this, that is called as a re- reperfusion we call it. So for reperfusion, the obstruction the obstruction for that, it is very important that it has to be removed urgently. So in that case this agent is used. Also in acute ischemia stroke, I told you altiplus is preferred in that. They has to be given parenterally because these are enzyme like structures given intravenously. Side effects, again they will cause hemorrhage because they are causing rupture or destabilization of fibrin clot. So these are definitely will cause an hypersensitive reaction and reperfusion arrhythmias. These are the major adverse effects they can cause. Reperfusion arrhythmia only in MI, because if it is stroke or DVT, then there are little chances, but yes, in myocardial infarction it will cause it. Contraindication, yes, all bleeding disorder, all these agents in this class, recent surgery, because if the wound is not yet healed, there are chances that the blood will flow from this, and severe hypertension, these agents are not to be used, because in case of severe hypertension, many times the blood vessels are becoming fragile and there are chances of severe bleeding from that. Okay. So hemorrhagic situation can arise, so it is therefore not expected. Drug interaction, there is increase in the risk of bleeding with dicumarol. All these agents, warfarin, heparin, aspirin, and all these agents of the class which are used in anticoagulation. In case of overdose, aminocaproic acids derivatives are there. Example, tranexamic acid is very popular. That causes inhibition of fibrinolysis by competitively blocking plasminogen activation. So these aminocaproic acid substances can be taken. We have just seen mechanism. I think, sorry, it came to. Yes. So we have seen these are the aminocaproic acid, which is inhibition of the activation, or it is anti-activating agents. So in that case it is used. So this we have seen. So inhibitor of fibrinolysis, yes, aminocaproic acid derivatives like tranexamic acid. These are clinically used. The mechanism is, it is the lysine analog that compete for lysine binding site on the plasminogen, and they block the plasmin to bind on the fibrin, therefore will not able to break down the fibrin. Where it is used clinically adjuvant therapy in hemophilia, where the persons are prone for hemorrhages, as a therapy for bleeding from fibrinolytic therapy, and prophylaxis for rebleeding in the intracranial aneurysms. Intracranial means inside the brain, or during stroke, whatsoever the aneurysm. I hope you have heard this word. Anybody? What is aneurysm? I think we discussed it in earlier classes, but still I would like to know whether anybody knows aneurysm. Okay, no one? No, they are not clot-like things. Anybody else? No, not tumor-like structure also. Aneurysm is the reduction in the thickness of blood vessel, particularly arterial blood vessels. मैंने एग्जाम्पल बहुत सारी बार दिया. I have given example that the tire and tubes are there, and if the outer tire has got a cut, small cut, then tubes can come out. So like that, if it is too thin, if the tire is too thin, then at any time it can burst. So aneurysm is like this. It is too much reduction in the blood vessel thickening. It is not swelling, rather it is thinning. It is Shubham, it is inverse of that. There is no swelling. There is a too much thinning or too much reduction in the size, and that can easily rupture out. So this is aneurysm. So when it is known that there was a stroke and there was a aneurysm, in that circumstances in intracranial aneurysm it is used. These drugs are also used in females where the during menstrual bleeding the bleeding tendencies are very high, but only it has to be given cautiously, carefully, or in other cases of bleeding where there is too much bleeding, and these are the agents which can control it. So these are used for control of bleeding. We have seen the mechanism. Side effects are intravascular thrombosis from inhibition of plasminogen activator. Okay, it can cause this kind of thrombosis, and which can cause obstruction, which can be dangerous one. The disseminated intravascular coagulation or genitourinary bleeding of the upper tract, in that it should not be used. Okay. Then the next in that case is aproteinin. It is also a serine protease inhibitor that inhibits fibrinolysin by free plasmin. It reduces the bleeding associated with surgery. There are minimal side effects are there, and it should not be used just like previous one in disseminated intravascular coagulation or genitourinary bleeding of the upper tract. Then antiplatelet agents, which are very popular, very commonly given, and we have studied them. We have seen the mechanism. I will repeat. Oh, this Pranav is joining now, almost at the end. Fine. So these are the agents which are acting at one or other layer. We have seen earlier the mechanism, what it is. We have seen that if there is a endothelial cell wall defect, platelets are aggregating towards it because of so many mediators are there, and on the platelet and surrounding tissues there are so many receptors. So the prostaglandins are there which are having IG means prostacyclin is having inhibitory type of activity, while the thromboxane A2, ADP, 5-ST, they will have stimulant activity of platelets. These platelets are stimulated, they are sensitized. There are receptors called as glycoprotein 2B3A types of receptors. These receptors make it possible to bind with the fibrins, and because of the binding with fibrin, it is making a structure of like brick and cement. If fibrin is a cement, then the platelet acts like brick into that. Okay, and thus it causes the, so sensitization is there. These are causing positive feedback, these are activated, there is a degranulation. Okay, and this causes activation of thrombin mediated fibrinogen activation or fibrin formation. So all these things come simultaneously, cascade of reactions, and because of this cascade of reaction, the platelets are activated or sensitized, and because of this platelet activation, it causes platelet plug formation along with the fibrin, and they play very important role in blood coagulation and clotting. So coagulation means we have seen only the coagulation factor. Here we are seeing platelet. Many times both are combined, used in combination depending on situation, or sometime when only platelet aggregation inhibitors can be given. So we can have the agents which are taking care of that. We have seen aspirin. Is there any need to discuss aspirin again? We have seen aspirin just some time before in earlier class also, and we have seen it last year while we studied the prostaglandins. Now I hope you all will able to answer which I ask. Okay, what will be the dose? Yes, what are the peculiar things we have seen about it? So it will, okay, it is up to 80 mg. Average is 80 mg, can go beyond that also. So it is used for prevention of atherosclerosis, thrombosis, transient ischemic attacks, unstable angina. In many cases, it is used. It is implicated in such kind of thrombus formations. It is irreversible thrombus or platelet aggregations or hemostasis. It is we know mechanism, irreversible cyclooxygenase inhibitor, and therefore it inhibits the formation of thromboxane A2. We have seen that if higher dose is used, it can also cause inhibition of prostacyclin, and because of inhibition of prostacyclin, it can cause the loss of benefits, the whatsoever vasodilation and other benefits prostacyclin is offering, that will not be seen. It can be administered orally. Adverse effects because of prostaglandin synthesis, there are many. GI ulceration, fortunately at lower dose they are not many. Hypersensitivity reaction and thrombocytopenia. Contraindications are bleeding disorders, hypersensitivity and Ray's syndrome. These are a typical one. Drug interactions with hypoglycemic agents, but like sulfonylureas, it inhibits the uricosuric effect of probenecid. So in that case it is not used, and if the overdose of aspirin is there, or many adverse effects are seen, particularly in case of Ray's syndrome or such kind of severe adverse effect, then we can give the we can make the urine alkaline, and because of this alkaline urine, this can be used for the this, it can be excreted easily. Then next in this, the dipyridamole. I don't know whether you remember last year while studying angina, I told something about this drug. Can anybody recall? So these drugs act on this ADP mechanism. So it is lowering the platelet calcium, it increases the formation of cyclic AMP. So it is a weak antiplatelet drug. It can cause vasodilation, particularly coronary vasodilation, but the drug is not preferred in angina. Last year we have seen it. Why it is not preferred? Because it I will give you clue, but you can study. It causes steal effect. STEAL. STEAL. Steal means stealing something, chori karna. So that's why it is not much preferred in angina, but it is a good choice in case of stroke and other such conditions. It is used in prosthetic wall, may be used as an adjunct with aspirin and warfarin. Benefits are with dipyridamole plus aspirin, they are debatable. It is not sure that it actually causes benefit or not, but yes, pharmacologically these are the actions, these are known actions. As I already told you, although the actions seems very promising as anti-angina, it is not used, or it is not preferred as anginal drug. Oral administration, it can be there. Side effects are gastrointestinal distress, headache, dizziness and rash. Contraindications are hypersensitivity to this drug. Drug interaction increases of bradycardia with beta adrenergic receptor antagonists if they are used particularly during angina. It is possible that beta antagonists or beta receptor antagonists are given or beta blockers are given. With this, there is a drug interaction of bradycardia can cause. Then next drug or next agent is taclopidine. This taclopidine is causing ADP-induced expression of platelet glycoprotein receptors, and because of reduction in the these glycoprotein receptors, fibrinogen binding will be there. If you remember GP2, 3BA, so GP2B and 3A type of receptor we have seen. So in that case, it is a problem. Pharmacokinetics, it can be oral administered, eliminated in the urine and feces. Side effect are nausea, diarrhea, bleeding, mild to moderate. It can cause neutropenia, leukopenia, thrombocytopenia. The bleeding disorders can be severe liver disease. It inhibits cytochrome 4p50. So therefore, whatsoever drugs are getting metabolized to cytochrome P450, there can be drug interaction with that. So this is taclopidine, which is there. Then very common or very popular medication is clopidogrel. It is inhibiting binding of ADP to its receptor, which are involved in the activation of platelet glycoprotein receptors. Almost this figure we have seen many times. I am not repeating the explanation. Okay, so these are GP2AB, and the ADP is acting. Okay, it is orally administered, eliminated in the urine. It causes nausea, diarrhea, bleeding, etc. Very commonly combined with aspirin. Very prominent medication, prevention of atherosclerosis, thrombosis, transient ischemic attacks, and unstable angina. It also prevents of stent thrombosis. So whenever the stent is put after the PTCA, that is angioplasty, in that case the drug is given as a continuation therapy or for the lifelong treatment till stent is there. The next is antiplatelet agent is its analog is prasugrel or efficient. Same impact, same mechanism of action, and same thing are there, only drug is different. Okay. Then next in that class, the pharmacokinetic changes these agents are having. What are the changes variety of these drugs are having? This is I think you will not able to see it properly. Only it is just rate of key endpoints during the follow-up period. So what are the endpoints which are there whenever the studies are going? So this is a comparison between clopidogrel and prasugrel, and it shows a very small variation in the things. Various endpoints are there, maybe quality of life, then the major endpoint is always the mortality rates, morbidities, situations. So in that condition, what will be the impact? And these two are that way comparable, both are. Then this one is MAB, means monoclonal antibody. So abciximab, so this abciximab is a monoclonal antibody. It is used in case of percutaneous transluminal coronary angioplasty or PTCA, what we call it as a. It adjunct with the aspirin and heparin it is given. It binds with the glycoprotein 2B and 3BA receptors, prevent the binding of fibrinogen, and binds with vitronectin receptors also. It is parenterally administered through intravenous route. The side effects are bleeding, thrombocytopenia, hypotension and bradycardia. It is contraindicated in aneurysms, bleeding, in recent surgeries and stroke. Drug interactions are not known, but being anti important problem it can have is again monoclonal antibody means is a protein molecule and can have hypersensitivity reactions too. Antiplatelet agents, they are used just like previous one, used in transluminal coronary angioplasty as adjunct with aspirin and heparin. They bind with the platelet glycoprotein 2B 3A receptors, prevent binding, and these do not bind to the vitronectin. It is administered parenterally. Side effects are bleeding, thrombocytopenia, hypertension, bradycardia. Contraindications are aneurysm, bleeding, recent surgery, strokes, and no big drug interactions are known. Hemostatic agents for bleeding disorders, what we can give is, so vitamin K can be administered. We have seen the mechanism that it is very important for synthesis of various cofactors of coagulation. So whenever there is less bleeding or bleeding disorders are there or insufficient bleeding is there, or what we can insufficient bleeding control is there, I am sorry, or the too much bleeding is there, to avoid it we can give vitamin K. So we know now vitamin K mechanism, that is, it is important for synthesis of factors 9, 10, 12 and prothrombin. So these 4 important factors are formed or synthesized in body with the help of vitamin K, and therefore it is very important. And for that if we increase the concentration of vitamin K, the cofactors can increase, and thus it can cause increase in the synthesis, or it can cause increase in the coagulation. Directly some of the factors which are available, either blood fractionation products or plasma fractions product, and some of the can be available as a recombinant technology, some proteins can be made. So these are the factor 8 is available, factor 9 is available, and freeze dried concentrate of factor 9, factor 10, factor 7 are available. These factors can be directly administered. These are the plasma fractions we can call, and because of that they will help in the control of bleeding when the bleeding is very excessive and it is not controlled. Then other is the analog of vasopressin, that is desmopressin acetate, which increases the factor 8 activity, and this can also be used as a factor or important factor which can control the bleeding. So here we have finished important in last 2-3 lectures. We have finished the all the agents which are responsible for hemostasis, may it be blood coagulation or against the hemostasis. So may it be coagulation, may it be platelet activation, okay, and against that are anticoagulants, and which are plasmin activators, etc. So all these drugs which are particularly focusing on the platelet and hemostatic or coagulation pathway in positive or negative way, that we have seen it. Our next will be on the hematinic or other hematinic and such kind of drugs which are particularly related to other functions of blood or RBC related functions of the blood. So I hope this much is understood, this is clear. Are there any difficulties? Okay, fine then. Okay, take care.